Welcome back, everybody. That 5 minutes goes by super duper fast. Okay, so moving on to our next presenter. Before we do that, I want to make a little quick housekeeping announcement, is that please make sure to visit our photo booth right around the corner when we have breaks later today. They have some really cool things that you can take pictures, and we want to get all the pictures that we can. So make sure to do that. But our next presenter is Dr. Mary Scott. She's a pediatric endo and executive director of clinical development at Calcilytix. So we're very excited to have her on board and speak to us a little bit today about Calcilytix. Welcome.
All right, good morning. Thank you all so much for the invitation to join you. A few of my colleagues and I are thrilled to be here with you this weekend. And I'd like to spend a bit of time today going through the different genetic causes of hypoparathyroidism, and then I want to talk to you about the development program that we're working on at Calcilytix for patients with autosomal dominant hypocalcemia type 1, which I'll refer to as ADH1 because that's a mouthful, towards the end of my talk. Okay, and a disclaimer before we get going, I will be talking about encaleret, which is an investigational drug, and it does not have health authority approval yet. And then who we are at Calcilytix. So you're probably wondering, why is there a name of another company up there? But Calcilytix is a sub-company or an affiliate of a parent pharmaceutical company called Bridgebio. And our mission is to discover, test, and deliver medications to treat patients who have genetic diseases or have cancers that are caused by genetic diseases or genetic changes. And one of those genetic diseases, as you've probably already guessed, is ADH1. Now, I know that people in this room probably know hypoparathyroidism better than anyone, but what you may not spend a lot of time thinking about are the underlying causes of hypoparathyroidism, with the exception of why you personally have this disorder. And so by far, we know the most common causes of hypoparathyroidism are post-surgical. So of all patients that have hypoparathyroidism, 70 to 80% of them are caused by post-surgical. The remaining three categories require a bit more detective work by your physician to figure out which one you might fall into. There are genetic causes, which make up roughly 10 to 12.5% of cases. There are autoimmune causes, which we think make up less than 10%. And then the other category are idiopathic or unknown causes of hypoparathyroidism. And as Dr. Schobach talked to us about yesterday, this is often when your physician has performed all of the testing to try to figure out why you have hypoparathyroidism and nothing comes back on the lab results. And I would note that part of that workup in my mind includes genetic testing, because I've met a number of patients who have been given the diagnosis of idiopathic hypoparathyroidism, but they'd never had genetic testing, and then once that was performed, they were able to figure out the underlying cause. So now we'll do a bit of a deeper dive into genetic causes of hypoparathyroidism. And I divide these into three different buckets. There are disorders that affect how the parathyroid gland forms. So when a baby is developing in their mother's womb, this genetic change occurs and the parathyroids don't develop normally. There are also disorders that impact PTH secretion. So patients have parathyroid glands. They're just either not able to make PTH or they're not able to secrete PTH. And then the final category are genetic changes that result in damage to the parathyroid glands. In this table and the one on the next slide, I have included all of the causes of genetic forms of hypoparathyroidism. And don't worry, I'm not going to talk about all of these, but I did just want to give you the information that as of today, we're aware of 26 different genes that, when they have a change, could cause genetic hypoparathyroidism. And so in these tables, you can see the specific gene on the far left column, the name of the condition that it causes in the middle, and then on the right-hand side is the inheritance pattern. And we'll talk about that in just a bit in more detail, but what I want you to note is that there are different inheritance patterns, or how this disorder could pass through families based on the gene that's impacted. So these are the disorders that affect parathyroid gland formation. And one of the other things that I wanted to note is that some of these are part of a syndrome. So when we talk about a syndrome in medicine, it means that typically there are multiple different medical findings that can occur in a given syndrome. So you might have hypoparathyroidism, you might have heart structural changes, you might have immune system changes, and so some of them only affect the parathyroid glands as far as we know, and then there are others that can affect other parts of our body. And then this is the second table that includes the disorders of parathyroid hormone secretion. You'll see that ADH1 is listed here, and then the final category is the damage to the parathyroid glands, and that includes the autoimmune polyendocrinopathy syndrome that Dr. Leonakis spoke to us about yesterday. Okay, so to talk a little bit about the inheritance patterns, when your physician is seeing you and thinking about, do you have a genetic form of hypoparathyroidism, and then thinking about all of those 26 genes that they have to consider, one of the clues that can kind of point them in the right direction is the pattern of inheritance through a family. And so I thought we could walk through a couple of examples here. On the left-hand side of the screen is an example of autosomal recessive inheritance. Autosomal means that the gene is not on a sex chromosome, and recessive means that you need 2 copies of that abnormal gene variant to have the underlying medical condition. So in this example, the father, you can see his chromosome pairs that contain the genes, and he has 1 abnormal gene in green, 1 normal gene in purple, and he's what we call an unaffected genetic carrier. So he has 1 abnormal copy, but he doesn't have the medical condition because he needs 2. And then the mother has exactly the same condition. So what happens when these 2 people have children? And so then you see the kids on the bottom here, and we typically get 1 copy of each chromosome from our parents. And so if we do the different ways that we could divide them up, they could have 1 kid that would have 2 normal copies. They could have 2 kids that would have 1 normal, 1 abnormal, so the unaffected carrier, and then 1 child that would get 2 copies of the abnormal gene, and that kid in the turquoise would have the underlying medical condition. So if we do the math, there's a 25% chance that a person with an autosomal recessive condition would have a child that would also have that condition. On the right-hand side of this screen is an example of autosomal dominant inheritance. Dominant means that you only need 1 abnormal copy of the gene. And you can see that in this situation, there's a 50% chance that a patient that has an autosomal dominant condition would have a child that also had that condition. And then the final example is an X-linked recessive inheritance. This one is a little bit trickier because it involves the sex chromosomes. So typically women have 2 X chromosomes and men have 1 X and 1 Y. And if the father has an abnormal copy of the gene on his X chromosome, he could have a daughter that's unaffected, an unaffected carrier, and then the son would be unaffected. But on the right-hand side of the screen, if you have a mother who's a carrier on the X chromosome and you have a father who's unaffected, there's a 50% chance that a son from these parents would have the condition, because with X-linked recessive, you just need one copy on the X chromosome if you're a man, because you only have one X chromosome, and then half of their daughters would be carriers. So if you have non-surgical hypoparathyroidism, why should you consider genetic testing? And my personal opinion is that knowledge is power, and it gives you information about why you have an underlying genetic condition. And this can help with understanding how to best manage you as a patient. If you're a patient with ADH1, for example, you might have a higher risk of high urine calcium than other forms of hypoparathyroidism, so your doctor may want to check your urine calcium more frequently and pay closer attention to where those levels are ranging. It also can help inform members of your family that also might carry the genetic variant. It can assist in family planning. And then importantly, I think it helps you to make informed decisions regarding potential participation in clinical trials. And you all probably know that there are some of the studies that are ongoing now that only enroll post-surgical patients, some that only enroll genetic patients, and some that enroll both. So because we think that there is value in performing genetic testing in patients with non-surgical hypoparathyroidism, at Calcilytix, we've partnered with a genetic testing company called Prevention Genetics to create this Detect Hypopara genetic testing program. And what this program does is provides no charge genetic testing for patients in the US and Canada. And so if you wanted to think about taking part in this program, you could do so if you have a diagnosis of non-surgical or idiopathic hypoparathyroidism, you have a diagnosis of low calcium that's thought to be due to a genetic cause, or if you have a relative who has a diagnosis of genetic hypoparathyroidism. And you can see all the genes that are included in this testing panel, which are the full 26 genes that we reviewed earlier on those tables that I showed you. And these are preliminary data from the sponsored genetic testing program. And Dr. Monstad actually presented this earlier this year at the Endocrine Society meeting. And this is as of March of 2023. We had 181 patients submit samples for the testing. The average age of these patients was 24.7 years, and the majority of the patients that were tested had a diagnosis of non-surgical or idiopathic hypoparathyroidism. And then you can see in the bar graph on the right-hand side of all of the patients that were tested, around 40% of them were found to have a variant that suggested that it was the cause of their underlying hypoparathyroidism. And of those 40% that had a variant, over 50% were found to have a variant in the calcium sensing receptor gene, which you learned yesterday is the cause of patients with ADH1. And so this data suggests and kind of supports what we've thought, at least in the medical literature in the past, that ADH1 may be the most common cause of non-surgical hypoparathyroidism that's not associated with one of those syndromes. And so because of that, we are working on a potential treatment for patients with ADH1 at Calcilytix. And I know that you all covered this yesterday in quite a bit of detail, but I just want to remind you that patients with ADH1 have oversensitive calcium sensing receptors. So that means that the calcium sensing receptor tricks the parathyroid glands and the kidneys into thinking that the blood calcium level is in the normal range, but instead it's quite low. And so when you look at the labs of these patients, they have low PTH, they have low calcium, and then they often have increased urine calcium. And so when they present, their symptoms are related to hypocalcemia. So they're the things that you all are well aware of, and some of you, I'm certain, have experienced. And when we look at the graph in the bottom right, around over 70% of patients do present with some symptoms that could range from mild to severe. And this is from the study that Dr. Roscoe presented to you yesterday. So our current treatment options for patients with ADH1 include calcium and activated vitamin D. This, of course, does not address the underlying cause of hypoparathyroidism in this patient population, and it has the potential to worsen or induce increase in urine calcium. And you can see an example of that in the graphs on the right-hand side of the slide. These were produced from one of the very first papers that described patients with ADH1, and the gray bars are baseline lab values that were before the patient started treatment, and then the green bars are lab values on treatment, and that's with calcium and then some form of vitamin D. So you can see in the upper left that the serum calcium was quite low at baseline. And then with treatment, they were able to increase the blood calcium. But the problem that we see is the next graph over, where the urine calcium also increases on treatment. And we know that this places patients at an increased risk for the long-term complications associated with ADH1, which includes calcium deposits in the kidney stones, and both of these place patients at an increased risk for developing chronic kidney disease. So with that in mind, at Calcilytix, we are working on a medication called encaleret, which could be a potential treatment for patients with ADH1. And this drug is an investigational oral calcilytic. That's a bit of a mouthful. Investigational means that it has not received regulatory approval. Oral, it's a pill, so you can take it by mouth. And then calcilytic is the class of drugs that this compound is in. And as you learned yesterday from Dr. Gaffney, calcilytics decrease the receptor's sensitivity to extracellular calcium. And you all know that patients with ADH1 have oversensitive calcium sensing receptors. So if the drug can bind to those abnormal receptors, normalize the sensitivity to the extracellular calcium, then we might see a correction in the low PTH, the low blood calcium, and the high urine calcium that these individuals have. And that's exactly what we're trying to do with the clinical studies that we're running at Calcilytix. And so you learned about our phase 2 study yesterday, and I did want to take a minute in case you're not as familiar with clinical trials, but a phase 2 study is typically the first study that is conducted in patients with the underlying medical condition that the drug is intended to treat. And usually the goals of phase 2 studies are to, 1, make sure the drug is safe, and 2, understand what doses might be needed for patients with the medical condition. So that's exactly what we were trying to do with this study, in which 13 patients with ADH1 were enrolled at the NIH Clinical Center. And as Dr. Gaffney walked us through yesterday, she was able to demonstrate that on encaleret treatment, these patients had increases in their blood calcium, their PTH secretion, their 24-hour urine calcium decreased into the normal range, and we also saw that the blood phosphate, magnesium, and 1,25-dihydroxyvitamin D normalized in these patients on treatment. Importantly, encaleret was well tolerated by these patients, and they've been on treatment for over 18 months now, and there were no serious adverse events reported in the study. So with this, exciting data from the phase 2 study, we were very excited and are very excited to move forward with our phase 3 study, which is called the Calibrate study. And so as a reminder, phase 3 studies are intended to compare your study drug and how safe it is, how effective it is, compared to the standard treatment for a given condition. And so that's exactly what we're trying to do here. This is an open label study, so that means that the patient and their physicians know what treatment that they're on for the entire length of the study. And we are trying to enroll 60 patients with ADH1. So there's a screening period where we make sure that patients meet the eligibility criteria. Some patients need adjustments in their standard of care dosing. Then they go into a period that's 4 weeks long, and we try to keep their standard of care doses stable. After that, they can be randomized to either the encaleret treatment arm or they would continue on standard of care. And randomized means that you're selected by chance to go into one of these two treatment arms. And for the case of this study, 2 out of 3 patients would go into the encaleret arm, so it's a 2-to-1 randomization. There's a 20-week period where we're adjusting the doses as needed to try to normalize the blood calcium, and then there's a 4-week period where we hope to keep the doses stable, no changes, and collect data on a steady dose. After the main part of the study, people can continue on treatment if they choose to, and those patients that were in the standard of care arm can start treatment with encaleret for the first time. The main goal of our study, which we call the primary endpoint, is to understand the number of patients on each treatment that can obtain a blood calcium within the target range and a 24-hour urine calcium that's normal, and that's on labs close to the same time. It's kind of hard with the 24-hour urine. And then we're also collecting other data, which you can see in the bottom right-hand side of the screen, includes labs and safety parameters. So these are the main eligibility criteria for the study. Patients need to be at least 16 years of age, and the lower cutoff is 18 years in Europe. They need to have a documented genetic change in the calcium sensing receptor on a genetic testing, either historically or one can be done at the beginning of the screening period, and then a history of a low blood calcium and PTH. They also need to have a documented history of signs or symptoms of ADH1. So if a patient is completely asymptomatic, they would not be eligible for the study. And then from an exclusion criteria perspective, patients need to be off of PTH treatment for 2 months prior to the study. If they've had a history of thyroid or parathyroid surgery, they would not be eligible. Pregnant, nursing women are not eligible. And if their GFR is less than 30, they also would not be eligible for the study. And this is a map of all of our study sites. And so you can see every time there's the little study emblem, that's a location of a study site. So we have a number of site locations in the United States, 1 in Canada, 1 in Brazil, a number in Europe, a few in Asia, as well as Australia. And you'll probably notice some familiar names at the bottom of the screen for the investigators, as many of them have actually been here with us this weekend. Another study that I wanted to tell you about is the Clarify study. So this is an observational trial, which means there's no study drug, and we are enrolling patients with both ADH1 and ADH2, which is another separate cause of genetic hypoparathyroidism. And our goal here is to learn more about the natural history of these conditions. And as Dr. Roscoe talked to us about yesterday, in rare diseases, it's really difficult to understand just what happens with a patient that has this disease, because there are such few numbers of people that we can learn from. And what we do know is based on publications in the medical literature that often include 1 family or 2 patients. And when we have those publications, they're often not doing the same testing or the same treatment. So it's really hard to compare and to know. And so for this study, we are aiming to enroll up to 100 patients. And I will say that we originally planned to enroll 60, and then we had such interest with both physicians and patients that we've recently increased that number, which is very exciting. And our goal is to follow them over a 5-year period and to collect the exact same information on every patient over the course of the study. And that includes medical history, symptoms, labs, both blood and urine, looking at renal or kidney imaging, DEXA scans like we learned about yesterday, and then there's an option for head, like brain and skull imaging as well. And we're very, excited to start to get this data, learn more, and be able to share it with you and the community as well. And these are the study sites for the Clarify study, again, throughout the world, and there's an active list of these sites on clinicaltrials.gov. So this is just a summary of the exciting work we've been doing with Encaleret over the past few years. And, this year alone, we're enrolling in that Clarify study, the phase 3 Calibrate study, and we've also started a proof of concept study in patients with post-surgical hypoparathyroidism that Dr. Roscoe shared with us yesterday. And then we're also very excited looking to the future. And I think I'm a pediatric endocrinologist, I'm thrilled that we're starting a study in children with ADH1 next year. So to conclude, the biggest points from our discussion today is that 10 to 12.5% of patients have a genetic cause of hypoparathyroidism. And genetic testing in patients with non-surgical hypoparathyroidism can aid in diagnosis, it can improve the understanding by you and your physician, and it can direct your management as well. ADH1 is emerging as the most common form of genetic hypoparathyroidism not associated with a syndrome. The standard of care for these patients is inadequate, and it can cause increased risk of kidney injury. And Encaleret is currently being studied as a potential treatment for these patients by targeting the underlying genetic change that's causing ADH1. We've seen thus far that the drug has been able to increase PTH and blood calcium levels, decrease urine calcium at the same time, and it's been well tolerated with no serious safety issues reported. And then finally, we are continuing to study the medication in a larger number of patients across the world in our Calibrate study. And then I'll leave you with this, and I feel like it might be preaching to the choir a bit, but I would just urge you all to stay connected and to stay informed with what is going on in the hypoparathyroidism community. And you've learned, you're here, so I know you are, but ways that you can do that besides coming to the meeting every year is to check out clinicaltrials.gov and do the search that Dr. Warren talked to us about yesterday. Talk to your healthcare providers. Ask them about research studies that are ongoing that you might be interested in. And then if you have any questions specifically about the information that I presented today, you can email us at medinfo@bridgebio.com, but I'm more than happy to take your questions now or, at a break as well.
All right, thank you. Let's give it up for Dr. Scott, Mary Scott. All right, so who has questions in the room? Okay. Deb?
Just to clarify on the Clarify study, it's for 0 age all through 90?
Yes.
So
great
we can
question.
have the children enrolled in this?
Exactly, yes. We're all comers.
Perfect.
All right, very good. Anybody else? Michelle?
I have lots of online questions coming in. First, since we just talked about the Clarify study, someone said, is there travel support for the Clarify study?
There is.
Okay. Next, can you explain how ADH1 and ADH2 are different? Is it the signaling that's also messed up?
Yes, that's a great question. So as we talked about, ADH1 is a genetic change in the calcium sensing receptor. And then ADH2 is a genetic change in the protein, the G protein, that this receptor signals through. And so often, and Dr. Monstad described this, that often the presentation of patients is similar, but it is a different specific genetic change, but in the same signaling pathway. So the question asker was right on track.
Okay. How many patients are you anticipating taking part in the international study for encaleret?
So for the phase 3 interventional study, we're hoping to enroll 60 patients. And then for the Clarify observational study, we're looking to enroll 100 patients.
Okay. And then could there also be a genetic component in a post-surgical patient who had hypercalciuria for decades before having surgery?
That's a very good question. And I've heard it before, and not only with the hypercalciuria, but if a patient had hypocalcemia documented on labs prior to surgery, there is a possibility. I mean, there are forms of hypercalciuria specifically called idiopathic, so you guys know that means we don't know why, that someone has it. And that's not that uncommon, so it could be because you could have hypercalciuria long before your surgery because of idiopathic reasons we don't understand. But it could be a genetic change. And so I think, the fact that genetic testing is, well, for us in the US, it's available at no cost and it's pretty quick, and you don't have to fight insurance companies anymore to get it approved, that it wouldn't hurt to do the testing. But I think it's probably one of the more common reasons we see it.
This question kind of goes along the same line, and you might have sort of just answered it, but it says, is it possible to have genetic hypopara if I was just diagnosed at 50 years old?
Yeah, it definitely is. So I think, from my own personal experience seeing patients that there have historically, as I just mentioned, it's been hard to get genetic testing. It's been expensive. You have to fight the insurance company. Some people, are worried that there could be other implications if they had a positive genetic test. And so for, I think a long time, physicians weren't readily checking the genetic testing. And that's why this diagnosis of idiopathic is heard a lot with people that have hypopara. I'd also say that if you have a milder form where you didn't present as a baby with seizures, or you don't have some of the syndromic features, that you could most definitely make it into adulthood without ever being diagnosed with the genetic form. And in fact, with ADH1 specifically, I've seen a number of parents who we diagnose their child, and then we say, well, we should check your calcium level and the dad's calcium level. And one of them was affected, and they had no idea.
Wow. Follow-up to that question is, do patients with ADH1 and ADH2 tend to stay at similar symptom levels or calcium levels as when they are first diagnosed, or do their calcium levels fluctuate as life progresses and drop to be more serious?
Yes, unfortunately, the calcium levels do fluctuate. And as you all know, and we've talked about a lot these past couple of days, depending on your activity level, your diet, your health, there can be quite a bit of fluctuation in the blood calcium levels. But one of I think the challenges with ADH1, and there may be other genetic forms that I personally just haven't seen, is that there can be fluctuations in the blood calcium that just aren't explained, where the patient was doing fine, and then all of a sudden they weren't feeling well, and their calcium level had dropped without an explanation. So it is one of the challenges in trying to treat patients with ADH1.
And then I have one last question on here. Would a predisposition to autoimmune diseases show up in genetic testing?
So for the The panels, the ones that I listed in my presentation, there is only one gene that has been identified to cause autoimmune hypoparathyroidism. So that is a possibility, but then there are many other genetic predispositions for autoimmune diseases, so I'm not knowledgeable enough to speak about what that looks like, but I can say as far as the genetic testing panel that I presented to you, there is the AIR gene that has been associated. And one thing that actually I'll note about that, just for your information, is when I learned about the AIR gene, I was taught that people usually have symptoms pretty early in life, in childhood, 5 or so, they have these candidal or yeast infections, and then around 10, they can become hypopara, and then things progress from there. But in our genetic testing program, we've actually, I think 11% of those 40 that had a variant that was identified had variants in the AIR gene. So I would have thought that they would have already known that, but it was detected at least in the testing program.
All right. Well, thank you so much, Dr.
Okay,
Scott,
thank
for
you.
everything.